Sounds good. So yeah, so diving right into it. So our patient is an 83-year-old male who I saw in Dr. Blackburn's retina clinic at the VA for evaluation of an elevated lesion of the left eye that had been previously seen at optometry on fundus imaging. At that visit, he didn't really notice any visual changes or visual symptoms or other symptoms, but he had recently been treated for metastatic prostate cancer in 2020. So a little bit more about his history. In terms of his past ocular history, he had an amelanotic nevus in the left eye, which is kind of the lesion that they were following. He also had some dry eyes syndrome, and also for his past medical history, he had hypertension, diabetes, hyperlipidemia, and the prostate cancer. For surgical history, he had a cataract and intraocular lens placement in both eyes already. Family history was non-contributory. For drops, he was only on some artificial tears. And then for medications, he had some blood pressure medications, some hyperlipidemia medications, and some diabetes medications. So in terms of this patient, I felt like it was really important to get a good timeline of the progression of the lesion. So in November of 2018, at a routine optometry exam, they actually noted a flat yellow 1 disc diameter lesion in the supratemporal region of the left eye on fundus imaging. And then at a follow-up visit in 2020, it was noted that it now had some mild elevation, but was otherwise stable. And then unfortunately, in February of 2020, he was diagnosed with castrate-sensitive metastatic prostate cancer, and he was started on hormonal therapy. So then over the course of the next year, he kept receiving treatment, and his PSA eventually dropped to 1.635 in September of 2021. So at the optometry follow-up visit after that, it was noted that lesion had remained stable during this time, and this was when they referred him to ophthalmology for further evaluation. So in terms of the patient's exam, it was relatively unremarkable. His vision in both eyes was 20/30. His pressure was good at 14 in both eyes. His extraocular movements were full. His pupils were round and equally reactive, and his visual fields were full. The anterior exam was also pretty benign. He had normal lids and lashes. His conjunctiva and sclera were white and clear. He had a clear cornea, a deep and quiet AC. His irises were dilated at this visit, and he did have PCLs in both eyes already. For the posterior exam, though, while the right eye was grossly normal, the left eye did have this amelanotic supratemporal choroidal lesion with possible calcifications and 3 flat pigmented atrophic lesions in the periphery. And this is kind of a picture of what we saw at that time. And as you can see kind of in the upper part of the screen, there is a kind of a circular hypopigmented area that's beneath the retinal vessels that has some possible calcifications. And I guess you can believe me that it's about 1.5 disc diameters, since the disc isn't in this picture. We also had optos fundus imaging from this time that showed kind of it in the supratemporal area again over here, and then these kind of 3 hyperpigmented flat lesions in the periphery. We also had a chance to get a B scan at the time, and does anyone kind of just want to call out what they see?
Elevated lesion that looks to be possibly under the retina. It's hard to tell from B scan.
Yeah, so
I know it is.
Yeah, that's pretty much what we did see. We saw an elevated lesion or a large hyperechoic raised lesion with high reflectivity, and there's some acoustic shadowing there as well. And by the measurements, it's about 3.44 millimeters elevated. We also had an OCT from the time, and you can see here that there's a raised choroidal lesion, but there's no active subretinal fluid and no retinal detachment. So in terms of a differential for this raised retinal lesion, does anyone have any thoughts on kind of what it could possibly be? It could be probably a lot of things at this point. Okay.
Primary cancer, metastatic cancer.
Yeah, so primary cancer, metastatic cancer. The kind of differential that we were working with at the time was one, we thought it could be a prostate cancer metastasis given his history of prostate cancer. It could also be a choroidal nevus or a melanoma, or an amelanotic version of those. It could be some kind of scleral choroidal calcification, a congenital hypertrophy of the RPE or chirpy. It could be some kind of vascular lesion or age-related disciform lesion. So that was kind of the working differential that we had. And just going through it systematically, We felt that these age-related disciform lesions were less likely given that he had no history of AMD, and usually these kind of scars have some visual symptoms, which he did not have. In terms of a vascular lesion, we also felt that this one was less likely, given that we felt that a hemangioma would kind of have more vascularity on the exam. And from what we see, we didn't really have too much suspicion of that. For congenital hypertrophy of the RPE, from the OCT, we felt like it was less likely, given that there was none of the retinal thinning or photoreceptor loss or the absence of the RPE that you sometimes see in it, and also his age and the appearance of like the lesion on the fundus exam. In terms of like scleral choroidal calcification, this was one thing we were considering. However, based on the OCT findings, we felt that it was less likely, given that there's not this like kind of rocky and rolly appearance of the sclera that you'll usually see with these sclerochoroidal calcifications. So what we were left with was just kind of like either prostate cancer metastasis or choroidal nevus versus choroidal melanoma. And at the time of this presentation, we actually don't know exactly what he has at this point. He's still undergoing workup and observation, but I thought it'd be interesting to talk about the first thing on the list, which is prostate cancer metastasis. So a little bit of background on prostate cancer choroidal metastases. So choroidal metastases are actually very rare. In a survey of about 9,000 patients with neoplasm, there was only really 6 patients who were found to have choroidal metastases. So that's about 0.07%. And prostate metastases to the choroid are even rarer and represent about only 2% of choroidal metastases. Usually the metastases to the choroid either come from lung or breast carcinomas, and generally prostate cancer classically goes to the lung or the bones. So one proposed mechanism by how it gets from the prostate to the choroid is it metastasizes to the lungs, and then it seeds the choroid. So in the literature, even though it's a pretty rare condition, there's about 24 reported cases of prostate cancer metastases or metastatic choroidal lesions. And interestingly, given kind of our patient's timeline where he was first noted to have the lesion and then he was diagnosed with prostate cancer, about 1/3 of the cases, these metastatic choroidal lesions were actually the first presenting sign. So in terms of a diagnosis, usually these lesions are diagnosed clinically, but based on like a history of prostate cancer plus an ocular tumor. And it's really important to get a thorough timeline of the progression of the ocular tumor and see how it responds to the treatments for the primary cancer. Biopsy is generally a very rare thing due to the like risk of damage to surrounding structures. And there's also easier biopsy sites for establishing a tissue diagnosis of prostate cancer. Occasionally, though, if the ocular tumor is the presenting sign and there's no way they're unable to find a primary cancer site, the nucleation and pathology can sometimes lead to the diagnosis. And this happened in 2 of the 24 cases. So some additional imaging that you can use to kind of augment the diagnosis are fundus photos, ultrasounds, MRIs, FDG PETs, OCT, and FAs. And you can see here, this is a MRI of a different patient, but you can kind of see that there's a ocular tumor here. And then on the PET scan, you can see that there's an area of increased uptake in that area. So for our patient, the additional imaging we got was the fundus photo, the ultrasound, or the B scan, and the OCT, which I showed earlier. In terms of management for these lesions, it's actually, there's not really too much data on the optimal therapeutic strategy since it's a very rare disease and there's no clear guidelines. However, the general framework of how you treat these is you're going to try to first treat the primary disease and also prevent further spread of the disease. So how this looks is you'll usually have some kind of systemic therapy, either like hormonal or medical hormonal therapy or surgical castration, plus either some kind of local treatment, whether that be eye sparing or enucleation. And the eye sparing ones are observation. You can also do episcleral plaque radiotherapy or external beam radiation. In our patient's case, he just had systemic therapy and he hasn't had any local treatment yet. So how do patients respond to these different treatment strategies? So again, there's a very limited sample size, but of the 7 patients who only had hormonal treatment, over 50% of them actually had a complete response, which means that with the systemic hormonal treatment, the tumor either fully regressed or almost fully regressed. 30% had a partial response where the tumor either stopped growing or like regressed a little bit, and 15% of the cases actually had no response and further growth and eventually needed enucleation. For the other treatments of external beam radiation and episcleral plaque therapy, there's similar results where like 40% of patients with EBR had a complete response, 45% had partial response, and then 1 of the 11 patients also had no response and required enucleation. So this patient's story is still evolving and we're continuing to monitor him, but given that the lesion has been relatively stable over the past 3 years, our current plan is just to have close observation and kind of monitor it with fundus photos and OCTs, and we're seeing him back in clinic in 3 months. So some of the main takeaways are that these lesions are often noticed on routine eye exams, similar to like choroidal melanomas. And often these prostate cancer choroidal metastases are diagnosed clinically. And it's really important, as I said earlier, to get a very good history of the progression of the tumor. Another thing is that the primary goal is first to treat the systemic disease and then prevent further metastasis. So you'll usually use some combination of hormonal treatment, surgical castration, and then some kind of local therapy. And then these patients already have metastatic disease, so extensive follow-up is needed even once the tumor is treated. So here are my references, and thank you for having me here at the rotation this month. It's been a wonderful time with all of you, and special thanks to Dr. Blackburn and Dr. Padilla for their help with this presentation.
That's great. This may not be directed towards you. I was wondering, would there be any reason to include choroidal osteoma on the list of possible diagnoses for this? It just was calcified. I mean, there's so few things that calcify in the choroid, and that's one that I just wondered whether it might be small choroidal osteoma. I've never seen one except in photographs. So
I don't know how calcified it is. I don't know how much shadowing.
There's some acoustic shadowing, I think. Yeah, but that clinical
Sorry, the OCT.
Not too much shadowing.
It has that really dense.
Yeah, it's just really bright.
I just don't know. Yeah.
Yeah. I think in the setting of the history of the metastatic cancer, it'd be harder to get to say. But
yeah. Well, and I think the unusual thing is, which I don't know, Sam, whether this came from your studies, is that choroidal metastasis to have one met. How often do we see just one met? Usually, if choroidal met, you have more than one, and so this is just a solitary lesion, which again to me would lean more maybe perhaps to something such as an osteoma. But again, I'm out of the things which I don't know.
Yeah. So, thank you, Dr. Stevens. In terms of like multiple mets to the choroid, I think that is often the case with kind of like metastatic lesions. However, in kind of the 24 cases, there were quite a few of them that only had one primary lesion.
Oh, there you go. Good. So that was helpful.
But I guess like one primary lesion in the choroid, but multiple metastases elsewhere in the body.
Did this guy have metastases?
Yeah, he had some bony mets as well.
He did. Okay. And did I know we have that one photograph, but did Optometry, when they were seeing him take photos over time, was there any reduction in or change in the appearance of it as he received his treatment?
So unfortunately, we only could really go off the notes. Tanya and I kind of looked back and tried to find some of the fundus photos from Optometry, but we couldn't find them. So it's hard to say. That's why we're kind of continuing to observe him and trying to get our own pictures.
You would get really dramatic shadowing behind this osteomas.
Gotcha.
And that's say you couldn't, but this I would expect from images on pictures. I would see that.
It's just kind of this flat kind of placoid.
Yeah, and then there's a lot of shadowing behind it, almost like a
Gotcha.
Okay. Thank you, everyone. And I think Katie has a presentation too.
All right. So while Casey's getting things loaded, this is she's our other medical student. He's coming from the University of Alabama to visit with us. By the way, Sam, that was a great talk. We'll be sure to say that. Right. And she is going to show us another cool retinal lesion. Retinal was been down. So this doesn't come up. You have to find a really interesting case. All right. That was quick. She's all set.
Okay. So I wanted to be a part of the whole Gray Round thing and I have no financial disclosures to start this. So I had to go with the agenda, just going through how everyone else does: patient presentation, imaging, differential, basic science, everyone's favorite, and a summary. And I'm going to pull up my notes. All right, so we have patient MD. Her chief complaint is 69-year-old female. She's presenting as a referral for cataract eval, but we are here, so this isn't a routine cataract eval. She supposedly has ARMD OU. So present illness, she reports her vision has gradually worsened since 2015 and states she started seeing floaters and flashes of light in her left eye in 2017 that have remained stable. Her view systems are notably in her right eye. She has watering, glare, and needs more illumination to read. Past medical history: no diabetes, no hypertension. There was a massive language barrier even in the site of having the interpreter, and she is from Africa. The first thing I wanted to start with is, can anyone just mention like a few things? What could mimic ARMD? Anyone?
Pathologic myopia.
So, yes, pathologic myopia. I talked about, had the pleasure of having Dr. Tabry and listened to her and different, I guess, things into adult villiform macular dystrophy, Cone dystrophy, Stargardt's disease, retinal artery macroaneurysm. So lots of different things can mimic ARMD. So I want you to start thinking about what could mimic this. Physical exam, looking at her visual acuity, best corrected is 20/50 bilaterally. Her pressures were good. Glare, not, quite, 2100, 2200. So yes, she does have a glare, but not dramatic. Her lens 1 to 2 plus NS. So not really a big cataract. Macula, though, is where it starts getting interesting. She does have scar nasal phobia, RPE changes, and she does have scattered drusen. So I'm going to start with the right on our OCT. And I apologize. We tried to get better OCT images, but weren't able to get it to load up on. So nothing really significant too much in the right, but we do see this small little plaque here. And we'll get to that on the next page. And then on the left, this is the more dramatic. This is the one she was mainly complaining about. And again, we can start to see little areas, which brings to the next fluid. So we saw tubulations as well on the outer retinal membrane. And looking at the differential, again, we see wet AMD, pseudoxanthoma choroidal neovascularization, and Stargardt's disease. After immediate evaluation, Paras and Dr. Katz, they realized that anterior segment it wasn't the cataract that was her problem, it was mostly the retina. So they went ahead and did a follow-up with retina. And as you see with the wide fundus photo, that it was definitely not the cataract causing her problems. Can anyone tell me kind of what they see typically? What this definition is? Has a great mnemonic. Everybody about
Angioid streaks.
yes. So this is angioid streak. She has it bilaterally. And I'm just going to go through the FA, and then I'll have them all on one page. So this is of her right eye. This is the one that we didn't see all the changes in the OCT, but she does have angioid streaks bilaterally. So early, mid, and late. And again, on the left, you can see the hyperfluorescence, and we can see staining, and then we can start to see the leakage. So this is on both of them. So again, we can see on both sides, we can see the staining, we can see the leakage, worse on the left than the right, which corresponds to how she is presenting. And for fun, we did include the fundus autofluorescence, and this can be useful in the case of clinically, if you're not able to see angioid streaks, you can still see it on the fundus autofluorescence. So what are angioid streaks? So it's a mineralization of Bruch's membrane resulting in breaks, and it's found radiating out from the optic nerve. The origin of the term was first used in 89 in a patient with retinal hemorrhages, and again by 92 due to the resemblance of blood vessels. Presentation I thought was typically asymptomatic, but it can present with decreased visual acuity or metamorphia. And so the fundus, irregularly dark red-brown streaks, and a poda-orange appearance radiating outwardly from the optic nerve. Differentials I thought were the most interesting. The first one was ARMD, and like we saw, it was the myopic changes, but histoplasmosis was also on there due to the similar scar formation. Prognosis is typically good unless there are choroidal neovascularization develops, as there's high recurrence rate. And typically you have to treat the underlying condition if it's systemic, and that's systemic in 50% of the times. If CNV is present, current research, when I was looking at, it yields anti-VEGF treatment most effective. They were doing studies on PRP, laser, everything, and nothing seemed to work except anti-VEGF. So the typical mnemonic that everyone talks about is Pepsi. Pepsi is pseudoxanthoma elastium, if where you have the redundant skin, and that's 60% of the systemic causes. EDS, which I thought was interesting because it's mentioned, but it's hardly seen in Pepsi. Paget's disease, it's in the 8% of systemic diseases where you can have the extraskeletal calcification. It's the older person that presents with decreased hearing, they have vertigo, they have bone pain, the typical older adult with all of their symptoms. And so you really have to be extra concerned if they have hard of hearing, if they talk about their hat being too big as the typical book presentation. And then sickle cell disease, which I highlighted because our patient was from Africa. And she was a native of Africa. And so keeping that in mind, it's only 5% of systemic diseases, but I wanted to be aware of, you know, where are the studies that are we looking at? Where is it being pulled? Because if it's systemic, it might be different if it's coming from our country versus other countries. And then idiopathic is 50%. So I wanted to just go over like what are the workup is a good physical exam, because as we see, pseudoxanthoma elastium, EDS, it's all about looking at the skin. Are there redundant skin folds? Look at their neck, just like you do in diabetes. Look at the skin. Do they complain about hyperaccessible joints? Anything, and you can ask about easy skin bruising. Lab tests, typically hemoglobin electrophoresis, skin alkaphos. You can do urine calcium. Outcome that we decided to do is the patient was leaving to return home to Africa and wasn't planning on coming back. And so we decided that it would be cost conscious and to follow health quality care, to not do the full systemic workup as it would not be followed up. So due to her left eye being the main complaint, and you saw all of the CNV, went ahead and did Avastin in her left eye. As a summary, I kind of wanted to hit on our patient and then more of a culture and kind of what I thought about UK as a whole. And so our patient presented for a routine cataract eval with a history of ARMD. And so on further exam, the macular degeneration was likely a mimicker of the angioid streaks, and the patient's symptoms were likely related to CNV and foveal involvement. And looking at research, initially you can have foveal involvement and it not be related to any type of symptoms, but the more it's involved and the more you have that vascularization, the more you're going to be symptomatic. And Paras was able to recognize this immediately, that the cataract wasn't the problem. You know, that's not her presentation. And he was able to realize that she doesn't need this surgery because it's not going to fix her. And so also due to the patient travel and the current research, we were able to get the appropriate treatment for her. I wanted to go over again the importance of the thorough examination. So cognitive bias could have allowed this patient to undergo a procedure that would have not targeted the underlying pathology, and performing a posterior exam despite this was an anterior segment complaint. And so being able to realize that the patient is often telling you what their problem is, and recognizing that macula changes and getting OCTs with same-day referrals to retina can lead to this patient being treated appropriately. And my last big bullet point was culture. And so residents were able to immediately recognize red flags and say no to unnecessary procedure and ask for help. They asked for help. Paras was able to ask Dr. Katz. Dr. Katz was able to ask retina with Dr. Abujabi and Nellis. They immediately went over and said, yes, we'll take a look. and everyone was able to get this patient in the same day. She was French speaking there. It took an extra hour because we had a terrible interpreter, and they just took their time and they kept the patient oriented. And so I felt that was a big reflection on UK and ophthalmology that you should be very proud of. So thank you for your time. And I've appreciated my time rotating here. And these are all my references. And again, I just want to give a shout out to Dr. Abijadi for helping me get the wonderful FA photos and for helping me walk me through how to do that, and for retina, as well as Melis, Paris, and Clay. So thank you.
Thanks, Emily. One quick clarification. She just didn't answer the phone when I tried to call her to be the primary care and the rest of the workup.
Okay.
So hopefully we will
Yes.
get the rest of the workup before she comes back.
Okay.
She does have one more follow-up coming up. So if I can catch her then. I think the language barrier is hard, but I do speak enough French to get through some of that. So we'll see. But otherwise, yeah.
Do you have anyone to refer her to back?
So they said that they have somebody back in their home country that they were seeing. They were just hoping to get cataract surgery in and out while she was here. So hopefully, depending on what everything looks like next time, another shot, but also trying to find somebody over there that she can see and have follow up with. But yeah, they just didn't answer the phone when I tried to get them to go. So that worked. Really interesting patient.
Yeah. Any other questions for DP or Dr. Abigail? Okay, great job. So we are giving you 25 minutes of your day back today. I love the way Dr. Sanders did that at our class.